Welcome to The Bone, the podcast that goes deeper. Here we cut through the noise and get straight to the core of the issues that matter. From real stories to raw truths, we dive deep into the conversations that shape our world and challenge our thinking. We're not afraid to dig in and get to the marrow of it all. Whether it's life, culture, or business in sports medicine, we're here to break it down raw and real. No filters, no fluff, just to the bone. With your host, Shelby Daly, we're getting to the bone. This is a clinically pressed, approved CEU podcast. Find the quiz to gain credit at clinicallypressed.org/courses. Clinically Pressed Company, making the complicated simple through results that give back. Find out more at clinicallypressed.org. Let's get started.
Welcome back to the Bone. Today we have Jim Raynor. He previously, in another life, was an athletic trainer and now is not actively practicing, even though he still has all the knowledge. Today I wanted to have him on to talk about some of the struggles that he's seen when he was an athletic trainer and when he's not doing athletic training, and kind of reflecting on how we can take away some of these points as athletic trainers and what we can do better in our professional practice, clinically and professionally. So welcome to the show, Jim.
Thanks, Shelby. I've been looking forward to visiting with you. I've put you off for 2 years, but now's the right time.
Yeah. Well, I wanted to start off with you giving a little background, history of your professional practice and why you left the profession, just to get us off and running.
Yeah, so product of the late 80s, graduated from then Southwest Missouri State University. They had one of the very few curriculum programs across the country. And they were one of the first programs to transition into an actual major. So back then, it was a program, but not an actual major. I graduated in '91, did my graduate work at the University of Oklahoma. Spent an additional year post-graduate school at from University of Oklahoma. Had a lot of experience with a variety of different sports and all the joys and fun that you get to experience as a graduate assistant at a university as such. It taught me a tremendous amount about life, about myself, about the world of athletics. Almost immediately, I had a job opportunity to start an orthopedic sports medicine program in Oklahoma City. I did that for about 7 or 8 months. There wasn't a tremendous amount of alignment, probably a lot of the things that we're going to talk about. It was my first true exposure into the healthcare world, the business of healthcare. Then I had an opportunity to come back to Springfield, Missouri, to start a brand new type of program with sports medicine, focusing on the pediatric and adolescent athlete in a primary care setting. And at age 27, I was named the director of this program. And during that time, you don't know what you don't know. And the beauty of being young is that you're just ignorant. And the gravity of what was in front of me, I had no idea. I was just like, yeah, I can do it. And then just endeavored to learn as much as possible. And then one thing led to another, continued to elevate through the ranks with hospital administration. And I was a full bore hospital administration for about, of my 27 years at the health system that I was at. I was in administration from a director level and above for about 26 of those 27 years.
Wow.
Yeah. And then, then had opportunity to work with the Olympics, led the Missouri State High School Activities Association Committee on Sports Medicine. Also represented the NATA with the Committee on Sports Medicine and Fitness with the American Academy of Pediatrics. I was one of 2 non-physicians on that. Doping control for the Olympics. So I'm grateful for the opportunities. When I found what athletic training was, it just clicked for me. I am deeply appreciative of the mentors that were in front of me, the Gary Wards, the Ivan Miltons, physicians like Dr. Bernie Griesmer, Dr. Brian Mahaffey, Dr. Rick Seagrave. Those gentlemen poured a lot and gave a 27-year-old kid an opportunity to grow and develop something that really grew as a model, I believe, not because of me, but because they gave the opportunity for creative thought process and business acumen to come into the sports medicine athletic training world. And so we had a really, really good run, and then I left the profession in 23. And so now I'm at a nonprofit utilizing all the skills, knowledge, the constant posture of inquisition and asking why has bode well for me in my current role.
Yeah. Well, and we connected on LinkedIn when I started, getting mouthy and posting different things. Not disrespectfully, but just posing questions on what the heck's going on. And you had reached out to me.
Right.
So
Discord, right?
Yeah.
It's, somebody's going to say, poke the bear. Somebody's going to say, for everybody that would say, hey, poke the bear, I would say, well, you're the person that's saying, get off my lawn. All right. So I think this has been a long time coming of a platform for actual dialogue. As great as some of the pages on the Book of Faces has been, you're hiding behind the keyboard and you can't get context across the message or the discussion just in comments left and right. And it amazes me when you look at things like that. It amazes me on the tribes that are formed awfully quick and how the athletic training world eats its own.
Mm-hmm.
It's amazing to me.
Yep.
And it really depends on what setting you're in. Everybody thinks your personal experiences translates to everybody else's experiences and situations, and that couldn't be farther from the truth. So I really appreciate that you found this medium of discussion, and I just hope it continues to grow for you.
Yes. Well, I had noticed, obviously I expressed some unhappiness on when I had gained some momentum on LinkedIn. And, what I tried doing it on Facebook. Facebook is a different beast, but it was just the lack of knowledge and biases, like you had mentioned, that were brought out in these different platforms. Facebook was very much my chickens with their heads cut off, it felt like. LinkedIn, there was a little bit more the discourse, as you said, the kind of open debate, able to show different perspectives, not box it in, which I appreciated. But also looking at other people that were bringing up problems, they seemed very demeaning, very negatively energized. It was more just pointing out the problems instead of trying to create the conversation and bridge people together.
Why do you think that happened? Why do you think and before we go any further, I am fully aware that a lot of what we're probably going to discuss is not unique to the athletic training profession.
Yep.
Right.
Exactly.
I'm acutely aware of that because almost everything I can paint this. If you want to find an interesting parallel path, take majority of the subject matter that you have brought up, that maybe we will talk about today, and I will overlay non-operative primary care physicians that are sports medicine specialists that went through fellowship trained and things like that. And I can overlay almost every problem that the ATs have, that group has the same.
Yep.
From recognition and access and patient demographics. So it's not super unique. So why do you think people became combative? Or why are people combative? Or why are people just coming out and complaining? What do you think?
It's lack of understanding and then an air of arrogance. There's like an ego that goes with, pointing out the problem. You think you are smarter because you're identifying a problem, but then if you don't have a solution or presenting it in a manner where people can actually talk about it, I think, like you had said, there's the keyboard what did you call them? Keyboard warriors. And so I think even in the political realm of federal things and all that stuff going on, I think people just like to put their idea out there. They think they're right, and they don't want to have to debate or defend their position at all, because they just think that this is my experience, it's my truth, and it's right. So those are some of the things I've seen outside of healthcare and in the general world also. And I've identified that face-to-face, these informal conversations are really important. So, that's where we'll probably talk about later. But NATA is really starting to chokehold themselves, as people don't want to go to these in-person conferences anymore because they can do their CEUs online. They're not really creating a lot of value to draw people there or marketing appeal. So, the numbers keep shrinking ultimately, and then we're losing that camaraderie, that face-to-face, catching up with people, or even meeting new people at the conferences. And I think that's where we're slowly drowning the profession also.
Okay, can we park in on that? Don't forget that, right? Because I think that's an important conversation. It really does, right? And I saw this happening about 17, 18 years ago. Okay, so let's parking lot that. But I'm not going to let you, I feel like I'm starting to interview you instead of you interviewing me.
No, that's fine. This is back and forth.
Right? This is supposed to be a dialogue. But I hear you, and I agree everything you're saying. But to me, that's all reaction. That's an emotional reaction. But why? But what's causing that?
Lack of transparency and information, ultimately.
Of the people, of what's causing people to be upset?
I think so. I think so. I think the national organization, I know we beat up NATA a lot, but I do think that they've awkwardly distanced themselves from their constituents. And I don't think that they are as they're not backing up what they are selling the masses of, come to us with questions, we're gonna work it out. But that's very much in the private realm. Social media, you have to be careful on what you're spouting out also. But I mean, even just my invitation to our national board to be on when they were looking for the new director was a very eye-opening experience. And I know public relations, PR is a big thing, but at this point, since I've approached them, they've had many other podcasts interview AJ Duffy, our president currently. It's just, I even sent the questions in beforehand and said, you guys can edit before I post. I gave all control to them. And, once I kind of started, they weren't even hard questions. It was just kind of, what are we looking for in a leader and what is the criteria? And they shut that down right away. And I thought that was very sad, and some of the problems that a lot of athletic trainers are ultimately seeing.
Okay. So you just You just correlated yourself to Joe Rogan. That's interesting. You're the Joe Rogan of sports medicine. Okay. All right. So I'm going to cut to the chase because I'm the king of asking the why behind the why questions. All right. Sure, Shelby. I'll tell you what my perspective is on that. I believe people don't know what they're upset at.
Yeah.
They know what they're upset at, or they know they're frustrated. This is a hot take. I'm not a true believer in burnout.
Okay.
I'm pausing for a reason for people who's going to be listening to this, like, what is that guy talking about? I believe there are multiple steps that take place before actual burnout, because if you've ever been around someone who is legitimately burnt out,
Mm-hmm.
that is in disaster mitigation stage. It's very hard to recover off of that.
Mm-hmm.
Okay. I believe what happens prior to that burnout, there's multiple degrees of this. There's something called moral injury.
Mm-hmm.
All right. And that term it came out of, unfortunately, battle. And if you look at the origins of moral injury out of battle, if you look at the Civil War, if you look at World War I, World War II, there was very clear reasons why, at least from a frontline soldier, they didn't like being where they were, right? That military personnel, they didn't like it, but they had a cause to rally around.
Mm-hmm. Then,
during the Korean War, and definitely during the Vietnam War, there was a lack of purpose, a lack of, why am I doing what I'm doing? If you look at the folks during the Vietnam War, I mean, the draft, I didn't sign up for this, right? But as a citizen, whether out of compliance or duty, I didn't sign up for it, right? And here they go, right?
Yeah.
Then that has just expedited for every conflict that's there. I mean, why do we have so much post-traumatic stress disorders or combat stress, post-combat stress with our military personnel coming back? Because if you ask a lot of these guys and gals, they can't identify why they were there in the first place.
Mm-hmm.
All right. So we could have a political, social, dynamic discussion on that, but I'm using that, and I'm not using the atrocities and the struggles and the absolute sacrifice of our military personnel into the athletic training world. That's not what I'm doing. So I feel like I'm always going to have to justify my stance on it. But the correlation is that we have folks within our field that are up against factors that they can't identify. They don't know the Baba Yaga around the corner,
Mm-hmm.
right? They don't know who the fight is actually against. And so, of course, who are they going to start pointing fingers at? It's the association that I pay money to, that I feel is supposed to be fighting these battles for me.
Yeah.
Right? And really, I think there's a lot to be discussed, and in my humble opinion, some responsibility at the feet of the association. I really do. But there's also plenty of responsibility at the feet of leadership from a district level to a state level, and then even into a micro level of where ATs find themselves employed.
Mm-hmm.
Right? So what we're seeing is it's lashing out or responses to frustration. Honestly, I think a lack of hope. because they don't see opportunities. If people don't have hope of bettering themselves or bettering their work situations or bettering their relationships, that's when people are like, they're either gonna like actually check out, or they're going to quietly quit, or just give up, throw their hands up in the air and go, I just got to make it the next however many years, or I'm going to find another field, another career, right? Especially when you compound our situation, the AT situation, is that, my goodness, 40 hours a week, 45 hours a week. Oh no, you'll work 40 hours a week. But then during the summer, you're going to be furloughed, or you're only going to be employed for 9 months. I mean, and it's interesting on how people want to raise families, right? With personal economic factors that come into play. And there are a lot of people in similar financial situations, but they have the bandwidth or the margin to go get a side hustle. Where's an AT going to get a side hustle? Right? With what time frame?
Yeah.
Right? So those are just little examples. So I think a lot of our colleagues and my former colleagues are responding in a way because they don't know which way to go. Right?
Yeah.
So with that, take a look at most, not everybody, right? So before all the stupid comments coming through, all right, I understand how I'm presenting this, but look at how many ATs in the high school setting. It's a department of one. Who advocates for them? And let's be honest, most ATs are servant-hearted people. They're caring people. They're behind-the-scenes people. I'm not saying they're not good leaders. That's not what I'm saying. Most ATs, when they're through school, and why they went to school in the first place, is just to take care of people, build relationships, take care of people, right? Most ATs, honestly, don't have a business bone in their body, nor do they want to be in legitimate leadership roles outside of athletic training. Head athletic trainer, right?
Yep.
Head football trainer, Olympic sports, whatever it is, the same models that have been there forever. So here's my question. This is my question for the profession. Well, actually, I'm starting much lower. It's so much easier to point fingers at, justifiably, at the National Association. But look, AT, what seat at the table do you even have in decision making?
Yep.
Zero.
Yep.
Some people do. Some people are blessed to have that opportunity. But okay, what seat and what's the path? Let's go into secondary school. Are you going to do it through the athletic department? With the football coach, who's also the athletic director, who's also evaluating you on your performance, right? Jump on the Secondary School Athletic Trainers Association Facebook page, and my heart breaks for those men and women who deal with that environment.
Yeah.
I mean, it's heartbreaking. Okay. Are you gonna go through the healthcare services of the school district? Okay. Have you had any conversations with the National Association of School Nurses? Their life is difficult. I think I messaged you one time on LinkedIn. I think it was in Iowa. They're saying, how about ATs being functioning as the role of a school nurse?
Because there's a
at
shortage.
face value, right?
Yeah.
At face value, okay, but has anybody talked to a school nurse and what their actual daily responsibility is?
Mm-hmm.
Like I told you, up to 80% of their work life is medication reconciliation and distribution, let alone behavioral issues.
Yeah.
So, AT, you want what again? Right? So, I think this is just surface layers things that I don't know. I don't know what the objective is anymore. And I didn't know what the objective was for the longest time. And where this really smoked me in my head, like right between my eyes, as a hospital administrator over orthopedics and sports medicine, that realization of where ATs actually sit in the hierarchy of healthcare was sobering.
Yeah.
And I understand the little campaign, ATs are essential. No, we were not. And what I say about that, look at the number of ATs who exited the profession at that time.
Yep.
And then the AT, Shelby, I did everything I possibly could to keep my people employed. You know what they were doing? Delivering trays, food trays. Yeah, the great temperature check, because that made a difference. So but I could only man X amount of doors for temperature check. I had people, because the PPE problem, accessibility problem was so traumatizing or so limited. I had my staff members in the disinfecting areas of pre-used masks. Right? So all those things. And despite that, and they were doing a great job, because ATs have great work ethic. Nothing's beneath them. And that's a whole nother problem. Great work ethic and nothing's beneath them. Highly compliant. We do not me, people do not know the word no. Right? And then the people who do know the word no,
we're very compliant,
come off as a spoiled snowflake, right? So, and my poor folks,
yeah.
I was just happy that they were employed, because this was early on. We had no idea what was going to transpire next. And despite that, they were let go. I lost 80% of my staff. Now, it was furloughed, but tell that to somebody who is making X amount of dollars, and now with your furlough pay, because you're unemployed, $325 a week. Really? All right. So that smacked me in the head when then I saw other professions being able to survive through that. Then my colleagues who are in the collegiate setting, they were doing testing and testing and testing and testing and policy and procedure writing and mitigation and cardiovascular testing and screening, with zero consideration of increased time, responsibility. Nothing improved in their pay. Nothing improved in their worth.
Well, that was at Caltech. We were the first wave of, as the athletic department, of introducing students back into the campus. And we took a high risk of doing that. Yet in the COVID pandemic, when it started, even though we're healthcare providers, we were pretty quickly furloughed. I don't know why you would get rid of your healthcare staff in the middle of a pandemic, but it did not matter.
Yes, you do. Now you know.
Well,
what is it?
They don't care. I don't like.
Why don't they care? Well, so let's assume positive intentions from folks. Okay.
Sure.
But why didn't they care? Why didn't they care?
Well, we weren't making any money for them. One part of
That's
it.
that's 100%, because what happened to the patient population?
Decimated. There was none.
There was none,
Yeah. Even
right?
though the student health was still functioning because they were tracking COVID cases and all that
That's
stuff
right.
from afar. But we
That's
didn't
right.
necessarily get absorbed into that to help them, even though they were short-staffed and overworked. There was no translation of skills at that moment.
So what does that tell you on the global healthcare economy and the position of ATs within it?
We're still not respected or acknowledged.
I don't think. Well, okay, yeah. Boy, you're
Technically.
negative. Yeah, you're
Oh
negative
yeah, we were
Nancy
being
today.
positive, sorry.
No, no. Yeah, I mean, for sure, right? But the other aspect of it, and people can say, well, this is where advocating for yourself comes into play. Okay, I don't know very many ATs who can advocate for themselves in the front of an executive vice president. I just don't. Well, when are you ever going to get that platform, right? Um, are physicians going to fight that battle for you? Oh, see, now I can say this. I can say this now because my employment isn't predicated on this.
Yeah.
I respect our physicians, and this is not everybody. Once again, I'll give you a clarifying point of emphasis. This is not every physician, but until it affects their bottom line,
Yeah.
and I don't blame them. Highly skilled, right? And this is something that ATs don't have.
Mm-mm.
They don't have the gumption to stand and say, this is my skill set, this is what I'm worth, and I'm not going to compromise for it, and I'm going to fight for it. Right? So I am not bemoaning what the stance that physicians have, but they're not very altruistic. They're just not, right? And I understand why, right? Where ATs show your value, show your value. What a crappy message. Value. The greatest value proposition out there in the world of sports medicine is athletic trainers. Want to know why? It's because hardworking, talented, empathetic people willing to do whatever for a pay point under most PTAs. That's
So
called value.
Well, so this is where if you're a healthcare worker or athletic trainer and you are for socialized healthcare, if you're not happy at where we're at right now, we are
Oh my
technically
gosh.
providing socialized healthcare in an athletic department.
100%. Right?
So,
So most people don't understand the difference between value and worth.
mhm,
Worth is what someone's willing to pay you. That's
yeah,
what worth is. And what matters. Shelby, I value you as a person. For me personally, right? I value all human beings, right? From a spiritual standpoint, faith standpoint, yes, I value you, right? But in my eyes, from a business context, what is your worth to me? If you were worth this, or if I was worth something to you, you would pay me to be on your podcast,
yeah,
right? Right? But I'm not worth that, but I am valued to be on your podcast just because of this discussion.
yeah. Well, and that's where in the business world, I mean, my parents worked with government contracts up and down the wazoo. They were an office technology company. Guess
Mm-hmm.
what? You could provide the best service, quality equipment, all that, all the bells and whistles. But if somebody beats you by a few $1,000s in their bid, they're going for that. It's not that they
Oh,
value them more, but dollars and cents wise, it makes sense on the budget line ultimately.
Oh, so kind of similar to like when Hospital A has an outreach sports medicine program and Hospital B has an outreach program, and they both employ ATs and both want that high school contract, and then they proceed to go who can get to the bottom of the barrel fastest.
Yep.
Huh.
Because it's all about
Huh.
marketing for that hospital ultimately. It's getting the name on the stadium or
Mar-
on the sideline.
marketing. Right. Marketing. Um hmm. Marketing, where so much of the healthcare decision is made outside of the individual control or influence of the AT. Huh. Especially, especially they're minors. It's a parent's decision. They have options to go to orthopedics, pediatrics, chiropractic, allopathic, naturopathic, um,
Osteopathic,
osteopathic.
Rolfers.
Depending on what state you live in, direct access to physical therapy. Depending on if Adam Halpern has his business up and running, you can contact them, right? And then there's Jim, the athletic trainer at high school, Canyon High School, with my sling bag on the sidelines, say, okay, yeah, you need to get checked out. And they come back, um, here's my note, I'm cleared. And you're going, what? Right? So what? That's just another example of the business model that is so fractured, right? So yeah, Jim, you're saying you said, well, Shelby, you said earlier, people can, it's real easy to point out problems, but what's the solutions, right? There is no way the NATA can solve any of that,
No.
right? Then on the other side of that spectrum is brand new grad, $75,000 worth of student loan debt, right? And I think that's being conservative for a lot of people,
A little bit.
right? 75 grand, I just need a stinking job,
Yep.
right? So they find a job, let's say Canyon High School. I hope there's not an actual Canyon High School. Canyon High School.
That's in
And,
California. They don't have
oh, is
licensure
it?
anyway.
I should say Acme High School. And they take a job. Their supervisor is the athletic director, who is also the head football coach. No policies, no procedures, or if there is, it's all verbal. You have three parents who is a nurse, an EMT, and a physician, and it's an OBGYN physician, and they're your medical team. You get the scenario,
Yeah.
right?
I've
But
lived it.
that poor little AT who just needs a paycheck because they got student loans is going to take that job without understanding the ramifications and the business model and the business structure that's in front of them. And then 2 years down the road, they have burnout.
Mm-hmm.
Why the burnout is because they are dealing with moral injury. They're dealing with things that they don't want to deal with or are not equipped with, but they're having to deal with it, and they're having to morally compromise what they know is right, or what in their heart what they believe is right.
Yeah.
That's where burnout takes place. You stay in that moral injury for an extended period of time, burnout's gonna take place, and it's not recoverable. That's how
Yeah.
come if you ask some people who have left the profession and they go, hey, here's an opportunity, something that you've always wanted to do, will you come back? And they'll say, nope. Why is that? Right? So it's the model. it's the business model. And I admire people like Adam who's trying to do something different, right? He's trying to leverage technology, something different. I hope he's successful. I
Yeah.
actually, but per your recommendation, I listened to you guys' discussion, and he is 100% right. One of the differentiators of an AT is that they are, I would call them, they are the healthcare navigator for the population in which we're serving. But here's the problem, and I hope Adam can solve this. The reason why we are looked as such because we're so accessible. I'm currently working in an international program with over 700 people. Once they found out what my background was, the amount of people that come to me, hey, this is hurting. What do you think I should do? Right? And of
Mm-hmm.
course, hey, I'll take a look at it, do the data. This is what you need to do. Or, do you know a good doctor I can go to? Well, of course, I've been here for 30 something years. Of course, I know who I am. Hey, can you get me in sooner? Of course I got it. So now, question is, how do I monetize that?
Well, that's the business structure that we have is any athlete or patient can walk through the door and they have access to you. And
There
we
you
don't
go.
have any appointments. We're
There you
seen
go.
on the sideline, we're in the clinic, we're in
Right.
the hallway. You can ask a question at any time and we will
Right.
get you an answer.
Right. So if Adam can figure out a way to monetize that, fantastic. All right. It goes, I will continue to go back to the business model, the operational model is untenable. And we've been operating the same way. You just
Mhm.
mentioned something about, oh, how many, I guess we're not supposed to call them um, athletic training rooms.
Clinics, whatever. Depends if you're still working in the closet or not.
I never had a room. My poor staff barely had rooms. They were converted storage rooms. But we're going to waste energy on,
Yeah.
don't call me trainer, call me athletic trainer. Call me, well, better yet, call me a certified athletic trainer because I have an identity crisis. Oh my goodness, I could go off on that too. All right. So what was I saying about athletic training rooms? Oh, how many rooms are set up to, whether it's in the collegiate setting or in the professional setting, in like professional sports setting, or in a club setting, or in a high school setting, middle school setting. It's 1 o'clock. It's a free for all, and it's like the stinking tsunami comes at them. I
Mhm.
don't care who you are. You have 20 people in your room. I don't care who you are. You're not giving good care.
Well, and there's a lot of HIPAA compliance that we've never actually
Oh my
acknowledged.
gosh. And documentation and the lack of paper trail. Oh, and I'm not talking about actual paper. If an AT is still operating off of pen and paper, really, you talk about compliance issues. Oh my goodness. And then on top of that, ATs who don't even know the difference between HIPAA and FERPA.
Yeah.
It's it's shocking to me, right? Let alone the inherent desire to feel important, and they just start talking about kids left and right. Or on the sidelines, there's no barrier
Yeah.
between the examination table and the stands, let alone no barrier to where auntie or mama or grandpa or whoever, if a kiddo gets hurt in the middle of a game, before you know it, you have a family reunion in the middle of the field.
Yep.
There's all this type of stuff leads to the moral injury because it's like, stop that. But so many of our people don't have the tools, the skills, the intestinal fortitude to go, stop, enough is enough. Or we got to put process in place or policy in place. So many people are just flying by in survival mode.
Yeah. Well, and I think it even with the paper trail, I was kind of going a different way because we're so distanced from financials and business function. I'm really tired of the collegiate high school settings with the return on investment argument because you are presenting that number to the wrong stakeholder ultimately. Your employer doesn't care. That's why they hired you, was to save money, but they're not having to pay for those extra costs necessarily. So
Absolutely.
why aren't you targeting that towards the athlete at the collegiate setting or the parents at the high school setting? Because they are the ones that ultimately are getting the cost savings from you being there, and they're not having to pay extra to possibly go to physical therapy or go and get an x-ray from urgent care or the emergency room. Those are your stakeholders that you're actually saving the money. And
Ooh.
I don't think that.
Wait,
Oh,
wait.
okay.
Ready? Send all comments to Shelby Daly.
We shouldn't have said your name at the beginning of this, I guess.
If you're on government funding, what do you care?
What, from the public colleges and high schools, public high schools?
Mm-hmm. If your insurance is publicly funded,
Mm-hmm.
okay, I'm glad that you saved me from going to. I could care less that you saved me money from an X-ray because guess what? I wasn't going to pay for it anyway. On top of that, how about the people who are uninsured
Yeah,
that will go to the emergency department
and not have to pay, or will never pay.
or will never pay? You're supposed to pay, but they don't.
Yeah,
So they choose the emergency department accordingly.
true.
All right, so there's that, right? The people. What what if you represent one healthcare organization over the next healthcare organization, right? How do you navigate that? Who are you loyal to? Oh, good Lord. Here's another tangent. How about the ATs who are held accountable to a quota of referrals?
Yeah,
So, but you're right. There's not an incentive. The return on investment. What's the real return on investment?
I don't know. You're providing free service. I don't know.
Here's another thing. If you're employed by the health system, why are you deferring? Why are you doing evaluation and holding on to people and saying, you know what, you can wait 72 hours. Let's see how this works. Meanwhile, you could refer that person in and they can get an x-ray, they can get a physician evaluation.
Yeah,
And so why are you right? So where does the AT fit on that?
true. That is true. So
Right?
the ROI debate like doesn't make any sense to me, and it
Makes
never
zero
has,
sense.
unless you're in
The
somewhere that has workers' comp, where there's money changing hands
Ooh, workers' comp. Do you think that our colleagues in the NCAA is ready
with NIL.
for the NIL, lost wages, work comp
I have no
model?
idea. I have no idea. I think they're avoiding it as long as they can, or else they would have already set a precedence for it.
I'm just waiting. I'm waiting for the first
Lawsuit?
collision of, well, it started happening a couple of years ago with the amount of people who were getting sued, amount of sports medicine providers being sued, and that's not specific to athletic trainers, that include physicians.
Mm-hmm.
Keystone State, of former athletes suing their healthcare providers for inappropriate care.
Yeah. Well, that goes to the model that you had just brought up. Is I've heard of colleges that have partnered with health systems, hospitals, and any athlete that the athletic trainer touches has to be seen by the physician also, even for a broken finger. Well, broken finger, you need an x-ray, but a finger sprain would be a better example, even though that can
I
be
have a
managed
better
in
one.
that.
I have a better one.
Yeah.
Concussion.
Yeah.
Why is an AT referring a concussed athlete?
Why are they or aren't they?
Why are they?
Liability, NCAA, I don't policy procedure.
Is that the reason?
Those are some of the reasons I've heard or used in my policies and procedures.
At the collegiate setting?
Well, I thought that for NCAA, the concussion legislation that passed, about 4 years ago now, there were some requirements for concussion care. But don't quote me on that.
So here's my question. Is it requirements for concussion? When is that supposed to take place? Is it when they're initially concussed? Is it for the initial diagnosis?
I thought it was clearance, but
Or is it for clearance? And then what is the physician doing for clearance? I know there's some concussion specialists out there that do everything from VOMs and I don't know. Are people still using
Scat 5?
No. Are people still using the computerized testing? Impact testing. Are people still doing that?
It's heavily relied on with Sway. Sway's the other one.
Yeah, impact, Sway. Okay, I can't say much about. Well, I can't say that. I'm just asking questions.
Yeah, that's fine.
How about at the high school setting?
Well, there's no funding for that.
No. So there are many state laws. So why is a physician needed for a concussion clearance?
I would assume liability, and it's a minor that you're working with. I don't know.
Oh, well, now it all depends on state law to state law because there's concussion laws all over the place, which is interesting that there's concussion laws, right? But like in the state of Missouri, clearances, I'm not going to get the words verbatim correct, but clearance by a qualified healthcare professional.
Yeah. Licensed?
Yeah.
Healthcare
licensed qualified healthcare professional. Right? So if ATs don't fit that bill, then nobody does. So when should a patient be referred? In my opinion, and I'll only talk for the state of Missouri. In my opinion, the only time that if the signs and symptoms are way off, whether you use SCAT5 or Sway or whatever, right? They're way off. They're multipliers, and there is not a reduction in signs and symptoms over 72 hours. Or, my goodness, you have one pupil that's dilated.
Yeah.
Obvious. The obvious brain.
Yeah.
Like, oh my goodness. Something.
Speech,
this is not an NTBI.
Decline. Yeah.
Right. All right. Why? Because you know what? The moment you say you need to have, where people go? If I'm mom or dad, I'm bringing them to the ED. Those poor ED doctors are like, not another concussion.
Yeah.
And how many times do we get the little note says, athlete not concussed, only has a headache.
Yep.
Right? So once again, it's the model. But Jim, so what's the solutions to that? I want to know who's sitting at the table of decision making.
Yeah. Well, I think I had brought that up in a post a while ago, and I kind of got my hand slapped by one of my superiors. standards of practice. What are those called? The articles. What are we calling those these days? Posted on the NATA. Wow, why am I forgetting this?
Like from position statements and things
yes,
like that?
position statements. That's the word I was looking for.
Oh.
When we are in school, we're only supposed to use research that's within the 10-year window. Well, what happens when our position statements haven't been updated in 10 years' time?
So you kind of mean like the continued struggle of adoption of core temperature assessment as a true means of exertional heedfulness, a differentiator between exhaustion and stroke. Huh. But no, let's continue to have the argument on it. Or how about this? The unreliability of heat index as a measurement mechanism versus wet bulb globe. Oh, wait a second. Has anybody even taken a look at the validation of the new apps that are out there that miraculously take weather coordinates and establishes humidity and direct sunlight with what sensors? Based off of what algorithm?
Well, and who decided that for lightning safety that it was 30 minutes from the last lightning? Who determined that? Where's the science on that 30 minutes? There isn't, I've heard.
Why is there a 10-mile radius versus an 8 versus a 6-mile radius depending on what state you're in? Or depending on what organization?
And
who makes that
Nevada,
call?
it's if you see or hear lightning, but Nevada is very flat, so you can see lightning past 10 miles. So, I don't.
Oh, in Missouri, there's parts of Missouri you can see lightning 50, 60 miles away.
Yeah.
Up, saw lightning. Time to go. How about in a full packed stadium? You're going to hear thunder?
Yeah. No,
right? Let
not
alone
really.
in collegiate settings and things like that. So standard. Okay. So are you talking about position statements? You're talking about policy, procedure, recommendations, association, school policy procedures. When I say association, whether it's high school association or the NCAA or the NJCAA, NAIA,
Your
right?
district, state practice act.
Who's making, right? It's so fragmented. So what I don't see is this constant in all of these areas of people who sit at the table. Who sits at the table? And not only just sit at the table, but you actually, it's not just a voice at the table. Because that's appeasement. I'm talking about decision makers at the table.
Yeah. Well, and that was, California, I have no idea when they're going to get licensure. I don't even know if they want licensure. I don't know if it's going to help the profession of athletic training to have all 50 states have licensure. But this last round that they went through, I watched all the videos from the presentation of why this bill should be passed. Many other associations came up and said it wasn't a good idea. One of them was the Physical Therapy Association. Guess who stood up and said that athletic trainers should not have licensure? A dual-credentialed PT-ATC.
Mm-hmm.
So the politics of it and the business of it, we obviously have not articulated any business means of, we're not necessarily stepping on anybody's turf. We could actually help create customers to an extent.
Yes, we are.
Well, we are, but at the same time, at the same time, though, we are in our own realm, but I guess it's a free market. So, that's why we're seeing PTs and EMTs starting to come on the sideline and take over our jobs.
Yeah.
So that's, I guess, I'm just trying to figure out how at the legislative level, how do we actually push back against these other organizations and associations that will undercut us no matter what, even though healthcare is a problem, there's not enough healthcare providers, yet they're still going to eliminate an organization that's providing healthcare because it's all about the dollars and cents.
Of course. Of
Yeah.
course, there's going to be, of course it's going to be dollar and cents related.
Yeah. But
And why should
we can't do third-party reimbursement still, so I don't know what the competition is.
Shelby. Oh boy. Who says we can't do third-party reimbursement?
What is it? Medicare, Medicaid? Which one is the overarching approver of insurance?
Okay, all right. Okay, CMS, Centers of Medicare and Medicaid Services, is the overarching for Medicare and Medicaid, right? And they will tell you what we do is not meant. Our role and function is only to control and influence the Medicaid services, Medicare and Medicaid services, not third-party reimbursement. They will tell you that.
Okay.
Okay. All of the big insurance companies will say the same thing. Okay. But the entities will say this. The healthcare providers will say this. We will follow Medicare and Medicaid services because that is the most strict and that is the most consistent across the board. And most health insurance companies fall in line with that because they're doing all the work, they're making all the policies, they're making all the procedures. Then all the insurance companies have to do is follow or adjust their payment rates, their payment schedules, negotiate rates, things like that. Does that make sense? So those ATs from my generation says, why are we wasting so much time to get Medicare and Medicaid approved, CMS approved, right? There's the reason. Okay. Well, the problem with that is that we never embrace that. We never embrace that fight. Okay. And one of the reasons why we couldn't embrace that fight is because of the patient population. Why would you want Medicare approval? You're infringing onto this population, onto this healthcare population. See, ATs are trying to expand their patient population, right? Meanwhile, ATs, best to my knowledge, are the only allied health profession who is limited by the definition of their patient population. Uh-oh. That was a compromise way early. That's how come some states, an athlete is clearly defined. Now we have a lot of states that have active population. Then even more so, some states clearly define what an active population is and what do they do in all of that mess. So despite the fact that we don't have a unified or standing principle of licensure across the entire United States, let alone not all of our states have licensure, period, that becomes problematic.
Yeah.
But I say all this to address your statement of, well, we can't get third-party reimbursement. Says who? I will come out and I will say this right now. My team did it for 20 plus years and still do it. All up and up, not hiding anything. The question is, if we can do it in lowly Southwest Missouri, why can't it be done in other states with favorable practice acts?
Yeah.
And what I think has happened is that historically we have acquiesced to the pushback from other entities, meaning, oh, we're not expanding our patient population. Yes, we are. We're expanding the definition of the patient population that allows us to have more access and so on and so forth. And what's wrong with that? To your point, where healthcare access is problematic. And I'll go back to the Medicaid kid.
Yeah.
For every dollar charged for a Medicaid kid, now this is different from state to state, I understand that, but you're averaging a reimbursement of 7 to 10 cents for every dollar charged. What business model wants to support that?
Not a lot.
Right? Wait a second, I have a 90 to 93% write-off of usual and customary charge? Who would support that? Well, you make up for it in volume. Okay. Not in the teenage population. No, you won't.
Yeah.
Right? Medicare is a completely different story because all our boomers and soon to be millennials or Xers, I should say, are going to access Medicare somehow, some way. That's a different equation. But we have ran from the fight of saying, okay, yeah. Do we have an access to healthcare issue? Yes or no? Do we want to bring access there? Do we want to filter necessary scheduling an appointment? So the value drive that you were talking about earlier, that's the mechanism. To Adam's point on your podcast about we have access to people who can healthcare navigate 100%. But we have traditionally run away from that fight, that conversation, and call it out what it is.
Yeah.
But once again, who's going to fight that?
Well, and I think that's where, we talked about the people that were combative in what they're posting about problems and stuff. We've kind of come into this professional victimization. And I think, pointing out some of the difficulties, problems, issues, whatever it may be, I don't know if people are actually looking into it, of gaining more evidence or researching about it, or trying to actually understand why we can't do certain things. One of the things I think that we need to start pushing back on, even though it does mitigate more risk on our practice, but I think we can do it, is physician oversight. I'm still wondering why we still need physician oversight in our practice, ultimately. If we're healthcare providers, we are technically
yes, you
working.
Do.
Huh?
Think that through. Yes, you do.
Why we need physician oversight?
Yeah. Don't think as an athletic trainer.
The referral process for them to make money?
So let's take the physicians out of the equation. Let's just go the system so we don't identify anybody in particular. If we're currently perceived as a marketing tool, indirect revenue, and whenever you have indirect revenue, and actually from a marketing tool, you're an indirect of an indirect of an indirect revenue, okay? You're expendable. If you are charity, you are expendable. Okay, so
Yep.
That is what it is. So let's look at the systematic approach of why a physician needs oversight.
Because you need the direct referrals?
I will say this. I will put it at the feet. No, you're still thinking as an athletic trainer. I would put it first at the feet of the individual AT. As an administrator,
Mm-hmm.
how do I know that you're worth anything? How do I know that you are clinically competent? How do I know not only that you pass, because when you pass your NATA, you are minimally competent. Congratulations. Huh?
BOC.
BOC.
Yeah.
BOC. Once you pass your BOC, congratulations, you're minimally competent.
You're entry level.
That's all that is.
Yep.
Your entry level. All right. What have you learned lately? What new skill set? What actual skill set that actually works? Right? Do you critically think of what you do and why you do and how you do?
Yeah.
Right? I first put that at the feet of the AT. And if you are doing it, how are you proving it?
Hmm.
Prove that. Okay? How are you being more and more clinically relevant and clinically trusted? So that's one reason why physician oversight is necessary. Take the politics out.
Yeah.
Take the business model out. I mean, those are two obvious things,
Yeah.
right? Governance is massively important. Nurse practitioners, PAs, still need physician oversight,
True.
and they get paid a boatload of money compared to ATs. They're not giving that up. And why do physicians want nurse practitioners and PAs?
Because they can take the non-surgical cases off their hands.
Well, you're not. So once again, you're only thinking
I know.
you're thinking sports medicine and ortho only. What else? You're right. You're right. You're right. It's a funnel system.
Yeah. The referral. Back to the referrals.
And I actually support it. I actually support that PAs, nurse practitioners, operate at the highest level of what their credential allows them to do. And that's something ATs don't do for a variety of different reasons. But I will still say the operating model and the business model and the process model doesn't allow the ATs to operate at their highest function. They are not empowered to. But if I'm a physician, I want them to operate at the highest function. But what is the reward? What is the incentive for a physician to promote that? There's going to be places where physicians just believe in what ATs do, right?
Yeah.
But there's a lot of places that that's just not the case. And so advanced practice providers, nurse practitioners, PAs, nurse anesthetists, they are an extension of the physician. Why aren't ATs an extension of the physician? Why aren't they modeling it after that same thing? I agree with you with physician oversight, but what does that really mean? What is that? And on paper is one thing, in actual is another, and then in the business model it's completely different.
Yeah.
There's so many opportunities if there's alignment as a physician force multiplier. But God forbid we say a physician extender because we got an identity crisis, just like, well, we can't call ourselves trainers. We can't call ourselves physician extenders.
Yeah.
Because we have an identity crisis. You know how many times I was asked or said, so Dr. Raynor, what are you a doctor of? Doctor of nothing? Right? I don't come out and say I'm a doctor, but if I function at such a high level, perceived high level, that they confuse me as a physician, is that a good or bad thing?
Neutral.
What do you think?
Technically.
Why is that neutral?
I don't know why we use doctor for everything. Also, and this is just a side note of, I'm not sure why everything is doctor. You can be a doctor of archaeology. You can be a doctor of whatever.
Mm-hmm.
Doesn't mean that you're a physician necessarily. I mean, it's hard.
It's marketing. It's marketing.
That is.
It's cultural acceptance. It's population acceptance. So if someone confuses me as a physician and I'm quick to say, hey, I'm not a physician, but I can bring this, and this to the table, they're like, oh, okay. Right?
If I'm improving your quality of life.
Right? especially if you have close collaboration, actual working collaboration with your physician. So I hear what you're saying about that. I will tell you, my take is that we should be closer to the physicians.
Yeah. Well, that's
And
when I was in the
in
college.
function.
Yeah. I'm the collegiate setting. I never saw our doctor. He never came to our games. He was just there to get x-rays and stuff if we needed
Right.
it.
My whole thing is, I and I have lifelong friends who are orthopedic surgeons. I don't want an orthopedic surgeon on my sideline.
No, I would much rather have an emergency room doctor. I'd much rather have a neurologist. Somebody
Right.
that I have a weakness.
Right.
It's redundant to have an orthopedic. They're not going to do surgery right there.
Now, I will have my doc on the sideline if he wants to do public relations. Their kids are playing, or they just like being a part of us. But I cringe every time I watch a game on TV, and then like 50 people go out in the middle of the field. I'm like, and they're sprinting, and I'm like, what are you doing?
Yeah.
Why? Now, when do you think the last time a non-ED doc did CPR on somebody? How about this? The last time a non-ED doc threw in an IV?
I don't know.
Probably
I don't see
a
what's
lot
in the
less than what
locker
we
room.
think.
Yeah.
Yeah, now you go south of the Mason-Dixon line, IV application or administration is significantly more frequent than the rest of the country, and I get that. And
yeah. But guess what? We're teaching IVs in the athletic training programs now.
Why? That's another question. Why?
You're not traveling with your doctor? I don't know.
How about
Ease
this?
of access?
How about this? Why aren't ATs getting taught how to do lac management?
They're doing sutures.
Not everywhere.
Not everywhere, but it depends how. I mean,
Well,
not everybody's doing
taught.
joint reductions either.
Yeah. What? Yeah. Okay.
I do it. I didn't suture somebody in the tent like my boss did, but.
So let me ask you this: right? This is where I lay at the feet of ATs. What's your criteria for a joint relocation? Are you going to reduce first time? If you're going to if that's a first time shoulder dislocation, anterior inferior shoulder dislocation, first time, are you going to reduce that in an adolescent?
Underage, it gets sticky. Depends if the parent's there.
Right. Well, even if the parent's there and the parent goes, put it back in. And let's say the humeral head is fractured through and through.
True.
Right? I just want to know what's your criteria, what's your process, what's your policy.
Yeah.
Who is making that? Who is the final determinant of that? What's the collaboration?
Mm-hmm.
So I'm having a central theme throughout this entire conversation. We can identify 1,000 different things, but at the end of the day, I'm still asking the same question over and over and over again. Who, with the authority, with the given authority, earned authority, is sitting at the table making these decisions? And we're not even talking about the business model yet.
No. Well, and I mean, from my knowledge and experience, I would say a lot of academia is sitting at those tables. People that aren't necessarily practicing on the sideline anymore or have ever practiced on the sideline are making a lot of these decisions.
You're not wrong. Can I throw another flavor on that?
Yeah, of course.
How are athletic trainers clinically ready for the field to be on them by themselves?
Good question.
Right? We can say all the different, the classroom and the clinical expertise and things like that. I want to compare. This is what I want us to do. And this is just a caveat to the proverbial system. In undergrad, how many evals did you do in a given day? On average, throughout your clinical rotation?
I mean, depended which sport it was, obviously, but I
Pick your
mean,
highest volume. Eval. I'm talking about eval with documentation, appropriate follow-up, all of that.
maybe one.
One a day, right? How many does a PA do in a rotation, in an orthopedic clinical rotation?
A PA, they usually have 20-minute appointment time, so that's 3 an hour times 8 hours, so about
There
maybe
you go.
18. But
Maybe.
in my clinic, it was about, well, she jumped from the doctor's to hers. It was about 52 in a day.
That's right. There you go. Hear where I'm going? How about the PA students? So many PA students get an opportunity to do the clinical evaluations, right?
Mm-hmm.
Physical therapy gets to do the same thing. Nurse practitioner gets to do the same thing. What do the ATs do? We get to stand
We
on the
sit and
sideline,
wait.
wait. We sit. We're the only healthcare profession that goes to the scene of the accident, waiting for the accident to take place.
For firefighters.
No, firefighters don't even do that. They sit in their firehouse and get
And
called
wait.
to it.
A little less distance, I guess. Yeah. Yeah.
Here's a question: Why are athletic trainers on the sideline?
We like to promote that emergency situations we can prevent death or assess for death risk situations.
Death
Helps.
risk. So really, that should be mitigation strategy before it ever happens. I agree with that.
Yeah.
Okay, but what about a response?
We're supposed to decrease the time of activation of EMS and supportive services.
Correct. Okay, so I think nationally, I'm not 100% sure. I think nationally, the mark of a great EMS response time is 8 minutes.
Mm-hmm.
Let's just use football as an example. Football practice in a college setting, in a high school setting, middle school setting. What's the response time if you set it up right? What's the response time from the athletic training facility to the field?
For an emergency response,
Yep.
probably around that 5 to 8 minute mark.
I would say it's less than 2.
True. Depends how big your complex is, but yeah.
But okay. So let's say you have a big complex, but where could you be based out of? There's so many places that have facilities within the stadium. And so my thing is, why if I had a half a cent for all the minutes I stood on a sideline waiting for something to happen,
Yeah.
I'd be retired.
True.
Why do we do that?
I think we're supposed to be multitaskers and being head on a swivel for incidences and doing rehab with people on the sideline and doing a bunch of different things because we're supposed to be efficient and cost effective.
Would you charge for rehab on the sideline?
For me going through a rehab? No, not necessarily.
No, would you charge?
Oh, would I charge as an athletic trainer running it on the
Yeah.
sideline?
Yeah.
I mean, ultimately, yes, but in my contract,
Great.
I can't.
No. That's besides the point. You would charge. Okay. Better question. Your best friend
Mm-hmm.
or your brother or your sister, whoever, whatever, is going through that. Would you want them to pay for that on the sideline?
Yes, because I know the athletic trainer's worth, but at the same time, they're there anyway.
The reason why I'm asking those questions is just because you're doing it on the sideline my question, just because you're doing something doesn't necessarily mean it's quality or it's effective.
Yeah. Well, that's when you have five athletes running around your athletic training room. You're taping, you're watching rehab, you're giving
It's no
someone
different.
instruction on how
That's
to
right.
put a Band-Aid on.
You know what that's called? That's called traffic cop sports medicine. Do this. Oh, good job. All right. Let's do 3 sets of 10. You know, the magical 3 sets of 10.
Yeah,
Everything's 3 sets of 10,
of course it is.
right? Let alone the quality of it, the true activation of what you're supposed to be, what's your goal? Right?
Proper form.
All that. I mean, we could talk so much about that. I'm just asking, has anybody taken a look at the model on how we're doing coverage, how we're doing therapies? Oh, good Lord. What? The pursuit of the third party dollar, athletic trainers across the country in the early 2000s up through 2010, 2012 were hiring other allied healthcare professionals who do therapy to work into their department. They have opened Pandora's box, and that box cannot be closed. Look at how many athletic departments, especially at high level universities, have PTs who do the rehab.
Yep. Even the professional level.
The professional level, right? We have abdicated our fiefdom. We have abdicated because we couldn't figure out the business model to make it work.
Yeah.
That's why I keep on coming back to the model.
Yeah.
It's just that same thing that I messaged you about abdication of roles and responsibilities in West Virginia.
Mm-hmm.
Coming through, West Virginia was held, it was Arizona and West Virginia held up to this esteem of people who graduated from there when I was coming through.
Mm-hmm.
Arizona got rid of their program. Now it's through AT still. I think they're still producing great people, whatever the case may be. West Virginia, now they have their first cohort for sports physical therapists. And then this is great. And the ATs are like, yeah, we're all a team. They do their thing. And I think, meanwhile, you're going to be standing on the sideline all hours of the day, all types of weather. They're going to be inside doing the stuff that you should have been doing while the team was practicing. That's my point.
Well, that's why physical therapists are starting to do emergency response courses now. To even
but why would they want to do that?
I don't know. They think it's fun and sexy. When I was working jiu-jitsu, I had many PTs and chiropractors that wanted to do sideline coverage with us to learn, learn how to do it. Because you get to be the hero, you get to respond. I mean, we had a lot of joint dislocations, we had a lot of lacerations, we had a lot of the nitty-gritty stuff that they don't get to experience, and they wanted to experience it because you're going to get a good picture of you responding to that injury.
Well, without question, it's great PR.
Yeah,
it's great
cool
PR.
Pictures.
And they probably have kids or family members, or they have a clinic within the community. I mean, it makes sense. I get it.
Yeah.
And there's reasons why physicians want to be the team doc for X, Y, and Z. You know that's a money loser, right?
Mm-hmm.
Direct dollar for dollar, that's a money loser for most physicians, most practice groups.
Well, I mean, you can look at the NFL on that too. ATs are there 24 hours, but they get to be part of the team. It's a title chaser or an organization chaser.
I used to tell the students in graduate school, and when I taught, it was people do a whole lot of things for the 2 to 3, 4 letters on their shirt.
Mm-hmm.
Man, that is an expensive logo, or that is a high-paying logo right there. Yep. That must be worth something.
Yeah. Well, so I guess going back to it on the sports physical therapy, even physicians, physical therapists, why don't we have an overarching athletic training umbrella with more specialties within it, do you think?
Why? Why do we need that?
Well, I mean, you have the cardiac physical therapist, you have the occupational physical therapist, you have
Mm-hmm.
the sports physical therapist now. I mean, even at the
Mm-hmm.
physician level, you have specialties. Do you think that, I mean, we're starting to kind of do that, but it's not really in our education. It's post-education that we go into these specialties.
What are you going to get employed as?
What am I going to get employed as?
Mm-hmm. Pick a specialty that we're doing right now.
Yeah. Well, I mean, there's the rehab portion of it, I guess, or performance,
Is that currently a
strength and
specialty?
conditioning.
No, I'm talking about like those new certs that are coming out.
Or
Those specialty
there's a high school
certifications.
one that's a mini credential, and then we have the orthopedic for the hospitals coming out. I just, from a marketing perspective, since athletic trainers are still the mystery of healthcare.
Who's going to pay for that?
I mean, we're making the athletic trainers do it through the masters now.
Okay, right. So the ATs are going to pay for it. They're going to do a personal investment in it, right?
Yeah.
And then what are they going to get hired as?
I guess it would help in the setting specialization, I guess.
I understand that, but what are they going to get hired as?
An athletic trainer. I guess I'm confused about this specialty certifications and all that, since we've been doing it already. I know that certain settings have caught fire and are, expanding very rapidly.
What's expanding though?
The opportunity of jobs and contracts, like
Is there an
industrial
opportunity of jobs, or is there an opportunity of education?
Both. I don't.
I want to know what they're getting employed by. What are they getting employed as?
Athletic trainers. Still.
And if they're not employed by an athletic trainer, what are they being employed as? Surgical techs? First assist?
Yeah.
Now there's like one or two states that I was aware of that allowed the AT to operate within the OR or whatever the case may be. Let's say the orthopedic specialty, right?
Yeah.
They can operate within the OR as a first assist or an orthotech, right? And then I think orthotech, if you pass your BOC and you accumulate, I think, over 1,000 hours of physician supervisory experience, you can operate within, with your surgeon in the OR. Okay. But even ATs, and then the majority of the states, even ATs who work as a physician, even ATs who work as a physician provider or with a physician provider in a clinic, what are they functioning as and what are they operating as?
I mean, they're still an athletic trainer.
They're an athletic trainer, but they're operating as an MA.
Yeah. And that's what I was at Pennsylvania Hospital ultimately.
Okay. So there's a dichotomy here. You have people who are being employed, but they're being employed as an AT and being paid as an AT. People who are employed as an AT, but are operating as an MA. And they're not functioning at the highest level of their education or what their license allows them to do.
Yeah.
In both scenarios.
Yep. That's why I left the hospital. I tried advocating and telling them all the skills I could do and where I could plug into the non-billable hours, since they couldn't figure out the third-party stuff. The non-operative appointments, all those type of situations. And they still didn't take me up on it.
Why not?
Higher ups. on the administrative side.
That's too easy. Why not?
It would change the whole system.
Too easy.
Too easy.
That's a too easy of an answer.
I don't know. I never got a full answer on it.
Okay, you've talked to a boatload of people.
Yeah.
Your leadership, your doctoral leadership studies has introduced you to a lot of different perspectives. Right?
Mm-hmm.
Cut to the chase. Don't point it at that's like us pointing it at the NATA that all these problems is the NATA's fault, right?
Yeah.
Higher up. Well, who's the higher up? So what's the reason?
Lost in translation, or somebody didn't have the energy to keep pushing it?
It is a value proposition, return on investment. This is so, why would I want to do this? Desperation is the mother of invention, and they are not there. So everything that ATs put their hat on is for a preventative model and a wellness and a healthcare provision, not a sick care provision. And our healthcare system is focused around sick care. And I understand why. So before we start throwing darts at the healthcare system, most people do not take care of their health.
That's the easy way.
100%. Right? So it's not a healthcare system issue. There is zero reward fiscally or time or effectiveness in a preventative healthcare model. Zero. Right? Well, you put that up against where the ATs try to show their value, they're never going to win that.
Causes friction.
Ever.
Yeah.
That's correct.
That's why gym memberships aren't covered by insurance.
Yeah. Yeah.
And why wellness checks, they only have you do it in so many years, not every year.
And wellness checks is a paper tiger.
Yep.
That's all that is. And for vaccines. Oops, I said that political hot button.
Yep.
Right? So why? Where's the revenue? Where's the worth? What's the return on investment? So at the end of the day, whoever it was, whether it's a collective group of people, a person, either a direct leader or the leader above your leader, looked at what you were saying and says, yeah, I hear what she's saying. I've got so many other things I got to deal with. This is just not worth it. And that's not even talking about the undercurrent of other healthcare professionals not paving the way. Why would they pave the way for you?
Your competition.
They're not going to. 100%. Why would another healthcare professional not say, you know what? Yeah, they're good for sports, but they're not trained. They don't have enough clinical relevance into what I do. Of course they're going to say that.
Yeah.
But no, let's open up our little fiefdom and let other entities come in because
we're allied healthcare professionals. Allied.
We're aligned. Just remember that there's always going to be, in all teams, there's always going to be somebody who's going to be at the bottom of the barrel. Oh my gosh, I said that.
Yep.
Some people choose to fight and claw their way out of that bottom of the barrel and at least trying to get on some sort of footing. But there is a hierarchy. There's always a hierarchy in teams.
Yep.
Know your role. Right? Isn't that what the New England Patriots said on their Know your role and do your job.
Yep. What a good conversation.
I don't know. I'm really nervous now that you're going to post it. I'm going to get freaking
I
people.
don't think you've said anything controversial, though, either.
I hope not. I love, well, I owe so much to the profession.
Yeah.
But now that I'm out, even more so. I mean, I saw a lot before, but now that I'm out, I just look at, I just feel for you guys. Well, look, someone who has been poking the bear and trying to make a go of it, trying to find lanes and asking questions and challenging the status quo. Look at your current trajectory. My goodness, that's an indicator.
Yeah.
Hey, by the way, I think you mentioned this with Adam in your conversation. Look at our NATA leadership. Where are they coming from?
Academia. Or they're on the border
And
of retiring. Border of
right,
retiring.
and fantastic. But I can tell you this, unless you're in academia, in which it's justified to do and to be a part of committees and associations and public affairs and things like that, boots on the ground people, me and as administrator, there's no way I can have X amount of time to be on a variety of different committees and volunteer my time.
Yeah.
That's tough to do. I'm not saying it's impossible, but that's a sacrifice of love and commitment. Same thing with our education, our clinical education. What's in it for the preceptor? Well, let's be honest. If you're at a small college and you have 500, 600 kids rolling through you have 500 to 600 kids responsibility, and it's you and your one assistant. And now you're supposed to clinically teach and give those students, those graduate students, great clinical educational experience and teach them through? Really? For a little plaque or a little shirt, or I do enough of that. Here's another one for me in the healthcare system on my therapy team. Why would I charge someone full price for a therapy session given by a student that's not certified yet? If they were certified and they were pursuing their graduate degree and they're already certified, they met minimum requirements. Yes, they're a student, but they're a licensed professional.
Yeah.
Of course, they're going to charge usual and customary, right? But our graduate students who are in ELMs, and they're not. How about this? You're a mom or a dad up in the stands, and you find out that a student is taking care of your kid at the college setting. Hammett, the GAs at the college setting, the GAs got to work on third string, second string. Tell me I'm wrong.
I mean, I didn't do GA. I didn't have GAs, so I don't know. But probably.
Or you get women's and men's tennis. Right? You get where I'm going? So I could throw darts at multiple education, but I will still come back to the same premise over and over and over again.
Yeah.
Where's the business mind? The operational business mind, operational business challenge. Where is that coming from? It's not advocacy. It's just not.
Yeah.
We have advocated on an individual basis till you're blue in the face. And even at that, what audience do you have to advocate for?
Well, and I think it goes into the saving lives, saving money. We're into the saver mindset. But business wants you to generate money is the biggest thing.
Okay. So let's take the money generation out of it.
Mm-hmm.
We read there was a tragic incident and there was a death on a campus, and one of the first questions on our social media pages was there an athletic trainer present? Okay, what if there is an athletic trainer present? So what? The next question should be is what was the emergency preparedness?
Yeah.
What was the emergency action plan? Where was that practice? When was that practice? What is the documentation for that? If it was a cardiovascular event, what was the response time of application of the AED? All those multi-level things, as opposed to, well, if there was an athletic trainer there, they would have saved their life. No.
Does anybody actually know the percentage of survival rate from a cardiac event these days? Still not very good in some instances.
Well, this is what I can tell you in some instances, and that's really wide and varied, and there's so many variables in there.
Exactly.
I would challenge anybody to look up what current accuracy of within standard of care of CPR done by EMS professionals.
Yep.
And they do that every day.
Mm-hmm. And how
many
often
times
do you
does it
practice your CPR EAP?
Right?
I just did an episode that released, so anybody listening, you might want to listen to it.
Right? We have all this sideline time. Meanwhile, we're more concerned about we got to get people ready for practice, or I got to get to practice. What about all the other things? You should not be paid. You should not be valued based on what they see you do. Because if that's the case, you're never going to get a pay raise. You're never going to get a higher salary point because it's reactionary.
Yeah.
The true value of an AT is in everything that they do prior to the event, during the off season, all of the processes, all the policies, all the procedures, all of the preparation, and in case something does sideways happens.
Yeah.
That's the true value. You can't sit there and tell, and even when that's all said and done, if unfortunately someone passes away or if there's a significant adverse event, then the question is, can you put your head down at night saying, I was prepared, we did everything to the best of our ability, and that's legitimately recognized and administered or recognized and documented. If you can't do that, what's the review process of an emergent situation?
Mm-hmm.
You know, what's the process of this is what happened, this is what we did really well, this is what we could do better, and this is what we're going to do next time.
Yeah.
See, where is that? I know that there are programs that do that. But across the board,
it's not
I am not
consistent
convinced
enough.
that happens.
Yeah. Well, and that's there's been a lot of proposed questions across LinkedIn of, I'll simplify and say, what business are we in? What are we defining ourselves in? But not touching into other specialties, which I think is silly and ridiculous. But I did a interview last year for secondary insurance, accidental insurance, and the way that athletic trainers can actually decrease premiums for secondary insurance is the prevention risk mitigation portion of our job. But we do not do a good enough job of documenting it or tracking those programs that we put in place. We're the burnout that you talk about, we're such in reactionary treatments and procedures and cares of rehab, taping, all these different things, emergency response. We are very good at that and it's necessary, but that's not actually the most concentrated thing that we are best at, good at, or what is, I don't want to say it's a money maker, but where that ROI actually comes in, where outside entities will acknowledge it with this cost savings or return on investment that a lot of people talk about. So we don't even have the right target on this return on investment per stakeholders or even the data that we are presenting or keeping, which is interesting to me.
Has anybody ever been able to prove secondary insurance decreased by X amount?
I haven't seen much, if there is.
Versus if you set up a process that it was third-party reimbursed. Oh. And that dependent on settings and all of that.
Yes.
There's a lot of nuances to that. So hold your comments to yourself, people. I understand that. Yeah,
But this boxing in of what we're trying to define ourselves as, people keep saying the jack of all trades, which I think is a bit demeaning, but at the same time, we are very good at the continuum of care, of being able to insert ourselves at any point of health for a patient. But I don't know if that's good enough
what's
for
wrong with
anybody.
jack of all trades?
I don't know. Everybody kind of not the master of none, but what is the full saying anyway? I just posted about this. I think jack of all trades is better than having to run around to each specialist in our healthcare system. To be honest, if you want to complain about the healthcare system, athletic trainers are the answer. They're able to refer you directly most of the time of where you need to go. That concierge
so jack of all
health.
trades are yeah. Well, is it concierge health or is it, once again, I'll use this term, are we the healthcare advocate for the active population? And does it have to be an active population? Healthcare advocacy.
Yeah. The quarterback for the patient.
If your car is clicking and you bring it to a muffler shop,
mm-hmm.
and all the muffler shop does is mufflers, they're going to evaluate it. They have one or two things. They're either going to say that has nothing to do with the muffler, or yep, it's your muffler. Meanwhile, it has nothing to do with your muffler.
Yeah.
It's no different in healthcare. Surgeons heal with steel. Right?
Mm-hmm.
Chiropractic heals with manipulation. Allopathic, I don't know what they heal with. Something. Right? Whatever works, whatever clinically justifiable, whatever. I'm using these as examples, right?
Yeah.
So my question is that not a strength of an AT to look at the person as a whole? Meaning musculoskeletal, neuro, nutritional, psychosocial, respiratory. I think ATs have the opportunity to be as close to functional medicine as they possibly can.
Yeah.
Outside of a functional medicine physician, I think that's probably one of the most underrated healthcare providers out there. And why wouldn't an AT gravitate into that whole body, mind, spirit? Because that's the missing component of American healthcare.
Yep.
We need specialists. 100% we need specialists.
It's the Eastern healthcare that hasn't really fully transitioned over here into mainstream health.
Yeah, and though, yeah. So, for instance, why would someone be sent to an orthopedic surgeon that needs a total knee and their BMI is 35?
Because the only thing that will get them out of pain to be able to function and be able to lose that weight.
Oh, you see the potential opportunities there?
Yep.
Let me give you this.
I thought that's what Ozempic's for.
Well, the reality is, hey, this is another hot take. I'd much rather somebody on Ozempic than deal with the slow death of obesity. I'd much rather have someone who's moderately, like let's say they're overweight and
Mm,
they try to go on a semaglutide or whatever. I'd much rather them currently, based on what I know now, I'd much rather them do that. Yes, I'd much rather them do great nutrition and physical activity. Yes, I get that. I'm just talking about the two things in hand.
yeah.
I'd much rather them do a semaglutide versus deal with sarcopenia because they're so inactive. That's
Yeah.
the number one cause of death. Correlating to death is sarcopenia
Hmm.
because they just won't move. There's no motivation to move, right? So there's this, clinically speaking, there's some give and take on all of that,
Yeah.
right? I'll give you an example of a business of a model that I think where ATs can find themselves and just thrive. And my colleague is still doing this to this day. I just texted him this weekend, and he does the walk-in clinic for I don't know, 35 something different orthopedic, primary care, sports medicine physicians, surgeons, total OD, sports, the whole hand, spine, the whole shebang,
Hmm.
right? It's a walk-in clinic. They go check in. Connor comes out, brings them back, and he triages them, and then he takes that person to the appropriate specialist.
Yep.
Who's better suited to do that than them?
I do think
And he's
that
got
is an avenue.
and he's got job security like this. And what
Yep.
we were able to do is establish if that person, let's say that person has a BMI of 35, they have chronic knee pain, whatever, why would they see the total joint surgeon for a clinic? Meanwhile, that person really should be directed either to a primary care sports med, a non-operative doc, or the physician assistant nurse practitioner of that um, total joint surgeon to talk to them. How long has this been going on? What other health, blah, 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 right? Because every minute a surgeon spends in clinic, that's not
Yep.
where they make their money,
Yep.
let alone the follow up.
Yep.
Why aren't ATs a part of the follow up crew? That, right? So that business model is in play here in Southwest Missouri and it's thriving. Okay. Those are the type of avenues. Is Connor operating at the highest level of his scope? It's closer. He feels he can do more. I believe he can do more,
Yeah.
but it's definitely closer. How many kids, how many patients did you see go into a particular doctor's office for a sprained ankle and they're coming out on crutches and a walking boot?
A lot.
What if they go to an urgent care center? That's exactly what's going to happen,
Yeah.
right? I use that in parallel to, oh, we need to do cardiac screening and everybody needs to do an EKG during pre-participation exams. Okay. Has anybody ever calculated the amount of false positives
Hmm.
and the required once that positive happens, whether it's false or negative, right? False or negative positive. Once that's established, and then that family has to bring them through that cardiac clearance. Has anybody ever put a dollar amount to that and it comes back negative?
Yeah.
Once again, that's an example of a business model. You asked it. One of my notes to say is what is the business model? What's the purpose? What's the objective? And but these are the questions that nobody asks when they get hired. And then they
Yeah.
run their problems.
Yep. Exactly. Did we solve the world problem?
No. I'm just
The
glad
meaning
that
of
you're
life?
doing it, not me. I'm done. I wish I tried really hard. I tried really hard, but it is what it is.
Yeah.
We had success, but
Yeah. Well, do we land the plane here? Or you want to keep going?
that's up to you, sister. I've talked way too much. I'm talking a lot more than I thought I was going to talk.
No. You brought up good points, though.
Okay.
I mean, I just think that, I've been preaching this for a while, is that the athletics department is not a good enough sustainable business structure for athletic trainers. They don't care. And the way that we're providing care, they're never going to pay into that system. I think the NIL might throw some curveballs their way and they may need to start looking at the medical model a little bit more in their departments, but we're not generating any money for most departments. Not that they're generating money at the D3 or D2
So
level.
Shelby, from a leadership perspective, do we really think they don't care?
They do. I just don't think that they are asking the hard questions most of the time. And I don't know if
I agree.
turnover, it's such a quick turnover. Can they really get stuff done? I think they could, but they are concentrated on other things in that short amount of time.
Every leader has to prioritize what's in front of them.
It's the surface level things that are easy to address and accomplish.
Well,
You have to have the rap sheet.
well, yeah. Well, I mean, a lot of the athletic departments, I think you made a comment about it, or somebody just recently did, about the role of the athletic director.
Mm-hmm.
I mean, it goes all the way down into the high school. We have athletic directors here in Southwest Missouri fundraising for indoor facilities, multi-million-dollar facilities, and the same athletic directors will say, we don't want to pay more for the athletic trainers, right? It's not that they
The
don't care,
facility's sexy. It's
right?
easier.
It is a prioritization. And even when something sideways happens, unless there's just gross negligence, then someone else is going to take the fall for that anyway.
Yeah.
I mean, unless there's something that happens like at the University of Maryland. That happened, 8 years ago, 9 years ago?
Yeah,
With the exertional heat stroke that took place and that young man passed away.
Yeah.
I mean, and then the Walters Commission came in and evaluated and said, I guarantee you, all the stuff that he identified was happening middle school, high school, collegiate settings all across the country. Was that a wake-up call? I think to a point. Has it been enough? We haven't had an unfortunate circumstance. Look, the state of Georgia has somebody pass away almost every year during 2-a-days.
Yeah. Obviously, it's not a good enough marketing scheme on trying to save lives. I'll say that out loud. I mean, we're having at the national level or the professional level. I mean, we've had professional women's soccer player, I think 3 weeks ago, collapsed on the field. A month before that, another collapse that was cardiac. I mean, NFL's had multiple cardiac events, and it still hasn't necessarily stuck with the public, with the athletic trainers. It's hot for about a few weeks, and then kind of people forget. So I don't think that's the marketing tactic we can take, of the scare tactic, or that we're saving lives, because obviously it doesn't matter.
If I was worried, if I saw that was happening to other people, then people wouldn't be smoking.
Yeah. It's
Or
not
the
close enough to home for most people.
right.
What about the smoker that
People,
lived to 102 years old?
right. Or the person who gets minimal health insurance, or the person who gets minimal car insurance, or gets car insurance for a month, holds on to the card, says he has insurance, but drives around without any car insurance. I mean, it's the same. That I'm not going to get caught. It's not going to happen to us. I'm not going to get fired. I'm not going to get let go.
Yeah.
Right?
Well, that's why the
It,
insurance system is the way it is. Nobody's going to work at their health.
correct. That's how come it's a sick health system as opposed to a sick system as opposed to a healthcare or preventative. And that is what it is, and that's okay. I mean, you
Yeah.
just you just can't bloody your stinking head up against the same proverbial wall, and that's what I think our profession has done for decades.
Yeah. Well, and I think people want results, not necessarily after an injury, but how has strength and conditioning professionals elevated so quickly in the last 10 to 20 years that,
What's your answer to that?
well, because they provide results. They've aligned themselves with the coaching staff ultimately. And then
Yes.
secondly, they are providing results for everybody wants the sexy data, how fast is somebody, how much can they lift,
The valued results, the metrics.
The outcomes.
Okay, great. There's a third component
Well, I don't know if they can directly or indirectly contribute to the outcome of the competition. I don't know.
100% they can. You want to know why?
Why?
They are the culture creators.
Yep.
Notice what I said. And kudos to them. They create the culture that the coaching staff wants and desires.
Mm-hmm.
And they're able to pull that off for a variety of different reasons, because during the off season, that's when you get better. During the off season is when you establish your pecking order. In the off season is where you show commitment, when there's personal development. All the things that ATs wish that we could have, or that we want to take credit for, to betterment and prevent and whatever, that's happening in the strength and conditioning world.
Yeah.
With metrics that are valued and a cultural influence that they have carte blanche at, under indirect direction from their coaching staff. That's why those guys get paid as much as they get paid.
Yeah. Well, and that's where, we said that we're in the sick society, but I think even if, not that we need to go out and become dietitians, nutritionists, but if we had targeted weight loss or something to that aspect of it, that's an easy outcome result that everybody wants. But how do you implement that into your practice? I'm trying to think of what measures we can bring up that are sexy enough for people to pay attention to and to acknowledge.
Sexy meaning valued metrics, and that's all dependent on a variety. There's a lot of things that contribute to what is valued, right?
Yeah.
Are you willing to stake your career, your position, your livelihood on an 18 to 22-year-old from an injury preventative model?
Technically, yes.
Wow, you're brave.
I tried at the MLS Academy.
And
They didn't like that I went against the culture of the coaches and the other staff members.
okay, let's assume that they were on board with it. Then what?
Mm-hmm. I
Injury prevention. So can we prevent all the injuries?
No.
What's the number one predictor of an injury?
Fitness level, biomechanics, dorsiflexion.
All the stupid things that we've been barking up the wrong freaking tree. It's previous injury.
Yeah.
Then the next level of that question is, okay, if the number one indicator of an injury is a previous injury, then my next question is, why is the previous injury still a factor in performance / injury reoccurrence?
Because it wasn't addressed appropriately the first time around.
Why do you think there's so many Achilles ruptures?
Overloading too quickly on their return to play. I mean, there's so many factors to it.
Like what? I mean, okay, overload might be one. Okay, what else? Are you saying return to play post-injury?
Yeah. They weren't properly loaded on their return to play.
Why weren't they properly loaded?
Because they had to get back on the court or field to play. I don't know. I don't know what those factors were. Incompetency, playing pressures, coaching pressures.
Okay. Well, let me ask you this then. Okay. Are there playing and coaching pressures in the NBA?
No,
I mean,
yes, but there's money.
Right. But that's guaranteed contracts.
Yeah.
3 uber superstars blew their Achilles out this past spring. 3.
Mm-hmm.
Did they have pressure to get back?
Depends what part of the season it was.
Was it okay? So was it coaching? It was all of them were towards the end, if not in the playoffs, right?
Yeah.
So I would accept personal pressure. Hey, it's the playoffs. This is what I was born for, right? I get that.
Yeah.
Okay. And I only want to work with people like that. Let's go, right? What do I need to do to get better, right?
Mm-hmm.
But that's different than, all right, let's go. And these are all the things that we need to address so that you can go, right? So load might be
so an
the
overload or an
mechanism,
underload, possibly.
right? But is that the actual culprit of the load failure?
Not necessarily. It's not the singular thing that caused it.
Right? So I will say there is a lack of understanding of tau-accrual neurologic deficit or compensatory patterns that take place that affect the entire posterior chain of the body.
Mm-hmm.
From the flexor digitorum to your soleus to your gastroc to your plantaris, all of it. There's a compensatory response. If I would come up to you and smack you in the head, you're just not going to do this, right? What ends up happening, especially when you don't know what's going to happen, is
big flinch.
Massive. Just put that on an ankle scenario. So what I'm saying is, I didn't mean it to be so clinical, but my point is, how do we want to be evaluated?
Mm-hmm.
All right, we use strength and conditioning as an example, but how do we really want to be evaluated or objectively measured? Is it an injury prevention program? If it's a true injury prevention program, man, you better be in sync with your strength and conditioning.
Yep.
Right? Same thing. You better not degrade the performance capability. I remember having a professional baseball player, and he goes, Jim, I hear what you're saying. But if all these things that you're having me do prevents from my ball from doing this and having action, I'm going right back to what I was doing.
Yep.
And then that light bulb came on. I'm like, wait a second. It has nothing to do with mechanics. It has everything with the body's resiliency to do those mechanics.
Yeah.
And we don't rehab that way.
Nope. Well, and we don't even take good enough outcomes to show our successes.
Oh my goodness, we don't
stuff.
even know how to do outcomes.
A pain scale is not an outcome. So that's where
in the sports medicine world, we compare outcomes up against other sick, other injured,
Mm-hmm.
as opposed to compare to the healthy population.
Yeah.
Then on top of that, what is the measurable objectives that are quantitative and reliable and of quality and is reusable and replicable? That's a whole nother conversation.
Yeah, we won't get into that right now. But that's where, going back to the strength and conditioning, they have measurable outcomes that
they do
contribute to the full picture of what they're trying to do as a team. So I'm not sure where athletic trainers fit on that spectrum still. I mean, it's not like you carry a file around to your new employer or to an interview of, here's all the success cases. I got this guy from A to B. I got the range of motion after surgery, and their performance was the same afterwards. And, they never asked for that in an interview. So it kind of goes back to your competency question of, you pass the BOC, you have entry-level competency. What else do you got? How do I know that you can actually execute what I need you to do at this setting and at this level?
Exactly right. Yep.
I mean, surgeons do it. They have to write case studies all the time.
Board certification. Their boards are based on what they clinically do.
Yeah.
Right? PAs have to do that, every 5 years, something like that? Or every 2 years?
It's like 3 or 5 years.
Yeah, I don't know what their rotation is.
Yeah.
Right? Why get more athletic training education? Athletic training education, which is such a...
Like continuing education or actual education?
Actual athletic training education. So the specialty certs. Why do that? I'll come back to that. We were talking about that earlier. What's the purpose behind that?
Legitimize what you're doing. I mean, that's where we're an athletic trainer no matter where we go, but
does that give you a job?
Sometimes. Depends if you're specialized in the sport that they need or not. That's where I didn't understand when I was applying for professional jobs. I wanted, I was trying to get the experience ultimately, and I thought I was a good enough clinician, but my background was in soccer, and the baseball teams wouldn't hire me.
Well, yeah, why? Why your sport experience? Why does that matter?
Because then you'd fit into the culture more. I don't know. They never gave me that answer. Because I would know the common injuries that would be coming through, and I would understand the return to play. I don't know.
Then that, to me, if we're going to have a specialty certification, then we should have baseball athletic trainer.
Probably.
Football athletic trainer. All right, when you say that out loud, it's nonsense.
Yeah.
So what I'm saying is, why do you need more athletic trainer, or athletic training education versus, I don't know, should it be athletic training, dry needling for athletic training? No, it should be dry needling.
Yeah.
Should it be athletic training for myofascial release? No, it's myofascial release.
I don't know. My mind went to skill set for some reason. I mean, I think that's kind of the beauty of continuing education and how we have it set up in athletic training is that you can go out and get more information if you need it in a certain area, but I'm not sure if you need an actual certification to qualify for those jobs. I don't know.
You don't.
I don't.
That's my point.
Yeah.
It's skill acquisition. It's knowledge and skill acquisition. Okay.
Mm-hmm.
Okay. We parking lot, and we're going way longer than I thought. We parking lot your thing about convention on
Mm-hmm.
how the annual meeting was going down, and I said, hey, can we put that to the side real quick? 17 years ago, 18 years ago, institutions outside of higher education stopped paying for ATs to go for continuing ed. The mindset is, and justifiably so, you need those CEUs so that you could be employed. That's not my role and responsibility. That's your role and responsibility. And I've been to those conventions, and 9 times out of 10, it's a social fest.
Mm-hmm.
So I'm not, right? So I had a staff of close to 70 people. I'm not going to be able to spend $5,000 on 70 people every year.
Yeah. Well, nobody would be there to work for 4 to 5 days.
And I can't shut down business operations. So we had to go on a rotating deal. But then all of a sudden, not all of a sudden, but then I saw the writing on the wall. I was like, listen, you're not getting any continuing education. So that's when I started bringing in continuing education, because I can pay somebody $20,000, educate 75 people,
Yeah.
not pay for flights, hotels, food, whatever else that people are doing. And here we are. So that model is broken.
Yeah. Well,
That's what's happened.
Well, and I think that goes back to our question on business operations. What is the business of the NATA?
That's right. It's advocacy. And we haven't talked about governmental affairs.
Yeah.
We haven't talked about anybody who is an actual athletic trainer who is in the corporate office.
Mm-hmm. Yeah.
But I fault athletic trainers. I'm one of them. If it was that important to me and I had all of my business background, why didn't I go for a candidacy and into the national office to do something different? But we're board driven.
Yeah.
All right. There's operations, but then there's a board drive. Right. And you're only going to get as good as what you're willing to pay people to. Ooh.
People don't work for free and put an output out.
I'm not willing to do it. Even though I love the profession, I loved the profession. So lots of problems. But what's a minimum starting point that we could do? What's a minimum?
Figure out how to do business better? Or is that still too big?
I can start there. And so what do you mean by that, Jim? All right. Let's identify one thing that we can create a process to strategically think around, strategically plan, create a process, create a guarantee of implementation, follow through on the daily, and see where that takes us. Can we identify one thing? Because the end goal shouldn't be, let's take, for instance, third-party reimbursement. It's too broad. That's like writing a dissertation on the broadest subject ever. leadership. My dissertation is on leadership.
Mm-hmm.
How are you going to condense that? How are you going to concentrate on that?
Well, and
Right? So
I also see it as right now, the NATA, I know we're not trying to beat up on one thing, but they are so dead set on splitting everything up in the profession, from setting to DEI to all these specialty certifications. Aren't they supposed to be the glue that holds us all together? I don't know if we're trying to move forward as a profession, why there's so much individualized acknowledgement in different areas that, to an extent, don't really matter.
I agree with you. And here's the reason why. There are two things that all organisms, there are two things, I'm going to make three statements, that all organizations fight. Okay? The failure to execute, to see a goal and an objective take place. I've yet to find anybody who can't strategically think that. I've yet to find an organization that can't come up with a goal, an objective, and a measure. The problem is the execution and the follow through to realize that objective, goal, and measure. Right? So there's always a difficult time of process execution that has a result.
Mm-hmm.
Number two, organizations can grow. It's almost like we can grow and I can identify things that we need to do, right? It's incredibly difficult for them to eliminate. Organizations have a hard time of eliminating. It's more than just saying no or not yet. It is eliminating. That is mission drift.
Yeah.
Right? That's number two. Number three ties into number two. The work is unending, but individuals are not. So I heard this, I think her last name's Funt. I forget her first name, dang it. The work is infinite, but I am not. So when you correlate the work is infinite, but I am not, into not having the ability to stop doing things when they're not effective, when they're not value return, when they deviate from what the actual mission is, there is no way you can accomplish the first thing of executing on your goals, measurables, and objectives. And that's pervasive through all organizations. The question is who brings that up and who has the cachet to say that, and then does leadership go, okay, it's going to be painful, but let's refocus. All I see, whenever you bring something up, you get dragged through the mud or justified. Not dragged through the mud. That. We appreciate your perspective, but here at the NATA, here at this committee, I chair this committee, or in my previous history, you are rationalizing and justifying the position of an organization. Meanwhile, your membership is plummeting, the morale is plummeting, and we continue to do the same thing as opposed to justify because you are in that inner circle. Almost to a person that you've brought on has towed the company line.
Well, that's many of my podcasts. Everybody toes the line, and then right when I stop recording, comes out how they really feel or what's really going on. And
That's right.
I know that you have to save face sometimes, but some of these conversations actually have to come out to the public so that people can navigate accordingly, or people can actually get involved because they know what's actually happening and may be able to address it. But
why
it's
would
the
young people
transparent.
get involved?
Well, I don't know. There's some
Why
people that
would young
still want to
professionals?
fight.
Why would somebody with a young family or kids who are in their high school activities. Why? Why would they do that?
I don't know.
So we shame them because, see, you're not advocating for the profession.
Yeah. You're not stepping up and putting in your duty.
You can't sit there and whine and complain about things without answers.
So is this the circle around to your burnout on World War all the
It
wars
is.
we've been in, and people are getting pushed into positions?
Yeah, I know we've talked about a boatload of things, but they're all interconnected.
Yeah.
They're all interconnected. And it starts with what Simon Sinek said. It starts with why. Why do we do it this way? If someone can answer me 5, 6, 7 times, this is the why, and this is the why, and this is the why, then okay, all right. I mean, then it's all right. I get it. And I don't even pretend to think that I know everything that's happening behind the scenes within the association, within everybody's individual workplace and stuff like that. But someone's got to ask, why is this happening? Why is this going on? Why do you continue to respond to your constituents the way that you do? Why don't you go on popularized podcast or why do you only go in echo chambers? Why are you only have the same demographics on your district directors?
Yep.
Why are you only recognized with what you do in the association as a part of the Hall of Fame, as opposed to somebody who created hundreds of jobs? Or a high school AT, why aren't they considered for a Hall of Fame recognition either in a district or in the state or in the national level that has been at a high school for 25 years, have invested in people come back to them? Where's that? But there's not valued in the association. It's, did you go through the channels? Did you start with the Young Professionals Committee? And then did you become the secretary, or did you become the social media coordinator? And
did you end up? Did you follow orders and indoctrinate into the system?
Now, youthful exuberance has to be contained, and I would say guardrailed. If the end goal is all the same for everybody, put guardrails and let that youthful, that early adopter thought process drive through. But we don't have that.
Yeah. It's more mentoring on the clinical skills than the actual guidance of the profession sometimes, is what I see.
I would say the same thing for the clinical skills, but that's besides the point.
Well, yes, but in the whole scheme of things, we're very concentrated on the clinical skills than the professional advancement. We aren't very good at teaching the soft skills and the business and financials. That's non-existent compared to some of the clinical skills that we're trying to touch on.
How many? If you want to do a little fun research project for you,
yeah,
just for knowledge acquisition, you've already done enough schooling. You don't need to do more school. Go back in the past 10 and national conventions and identify how many sessions were dedicated to building a business, building a leadership, third-party reimbursement, navigating through the complicated healthcare system, different business model strategies to think, and I would say it's less than 0.5%.
Yeah. Well, even hosting an actual debate at the conference. Why not have two people go at it and try to show different points of view No one has to win, obviously, but why wouldn't you show professional discourse and model it?
Can't. It's. I hope our country's moving more towards that direction. I think we are. I think.
Mm-hmm.
But it's tribalism.
But as a medical professional and in the science profession, I'm not sure how we become so tribalized in our opinions when science is ever evolving.
Because they're isolated. Because we're isolated.
We work by ourselves.
Shelby, we're isolated.
One person at the high school level.
You're one person at a high school level. You're one person at a small college.
And nobody understands what you do. So nobody can really challenge you.
You're in a massive collegiate setting that is isolated into X, Y, and Z. The guys across the hallway who makes 6 digits, multiple guys across the hallway make 6 digits a year, right?
Mm-hmm.
You don't have a senior administrator who knows and understands what you do and advocates for what you do and actually gets things done for what you do. The strength and conditioning coaches has the head football coach doing it for them. And they're the ultimate power. What do the ATs have? Some associate AD who's trying to move up the corporate ladder.
Mm-hmm.
That director of sports medicine, why aren't they? I think Baylor is onto something, by the way, Baylor University, where they have an associate athletic director of sports medicine. Now, I don't know what seat at the table he has, but that makes a whole lot of sense to me.
Yeah,
I'm hoping
UCLA
that model
has
gets replicated.
That too. I think no. There's somebody with that type of title, but he's still practicing at the same time.
I'm saying an administrator.
A direct administrator. No, I'm just reiterating what you said. I'm not sure if they're a direct administrator because I saw them still practicing. But they got the men's volleyball team.
Which is a big sport for them, right? I mean,
it is.
But so what's really worth? What's the value there? It's not the leadership. It's the fact that you're covering a sport. Yeah. I don't know if that's self-inflicted or if that's an expectation. I don't know. There's so many things I just don't know. And I don't want to assume.
And I guess I assumed when I graduated that the physician oversight for the college department, they had a little bit more power and influence and were actually involved in the administrative things, and learned that the hard way.
Not even close.
Which that's what I would assume an overseeing physician would be or would do when I was doing my education. That would be the ideal kind of thing, but athletic trainers can do that too, but we're not.
Nope.
I don't know.
So what's your take home?
Keep doing my business classes.
Keep doing my business classes. I just dropped my water. You just verklempt me. I was like, what? Yeah, to do what? Right? And yeah. I almost guarantee it's not going to be athletic training.
Yeah. Or it'd be an obtuse kind of not directly involved in athletic training.
Can I tell you everything you need to know about business and leadership you've already been through? Can I encourage you there?
Yeah.
If you're going to start your own business, you know how to balance your checkbook.
Mm-hmm.
You know how to do a personal budget. You've had to because you've been a student for however long that you've been. Right?
Yep.
And I know you're not highly invested in Bitcoin to where money's not an issue. So you've had to be very diligent. Right?
Yep.
You're well-versed in leadership. You're understanding how people are coming from. If you have an idea, now the question is, can you execute?
Yep.
Everything that you learned about people and leadership, you already learned in middle school. Life has taught you the business side of it. Just personal finance is no different than small business or business finance. It's no different.
Yeah. Yep.
Sometimes, Shelby, we just have to crap or get off the pot.
Yep. True that.
Anyway.
Well, since I've taken up so much of your day, probably should land it here. I appreciate you.
I'm going to be very interested to see how you edit this out. Oh my gosh.
I was just going to post the whole thing. What are you talking about?
Whatever. You better not 60-minute me.
Of course not. It'll be a 5-part series. But
man, we're talking about long form podcasts.
I
and
know.
You were comparing yourself to Joe Rogan. He doesn't do anything under 2 hours, so see?
Well, you are my first 2.5-hour podcast.
Hey, let's be true. It's 2 hours and
39
minutes and 54 seconds.
You know.
My gosh. All right.
Well, I guess I'll do my little thank you to you. Thank you for being so transparent and giving your opinion. I think it's valuable and that people need to consider these things as we move forward in the profession, or else I don't know where we're going to go from here.
Yeah. Shelby, I thank you for all you're doing. I hope you can continue on with the energy that you've been able to create on your own. Obviously, you have background support and some knowledgeable people that have helped you to get where you are. We all do, right? We all stand on other people's shoulders. But I am very appreciative that you wanted to take the time and visit with me. I encourage you to keep on poking the bear, asking the questions. But I would also say the same thing for all of my former colleagues out there. I empathize with you. I might come off a certain way, but at the end of the day, at the crux of the matter is that I just want more and hope for more for all of you that are out there in the community and this listening audience. Because what you do bring to the table is fantastic. I've gotten to work with a tremendous amount of ATs who are professionals through and through. I don't want to see the profession die a death of 1,000 cuts. And that is my concern. And I just want to encourage people to ask why. Ask why, and don't be afraid to try something different and change the status quo.
Definitely. The whole point of the show.
Yeah.
So, well, we'll schedule part 2 when you're ready. Not sure what we'll talk about there, but I'm excited.
You're going to get 2 listeners. You're going to get 2 listeners on this one. It's like, who's this idiot?
Nope. I think you'll get more traction than you think.
I don't know. We'll see. We'll see.
Well, thank
Hopefully
you.
This helps you.
Yeah, I think it will. But thank you for being on.
That's it for today's episode of To the Bone. I hope we've sparked some new thoughts, challenged your perspectives, or simply reminded you to dig a little deeper. Remember, life isn't just about what's on the surface. Sometimes you've got to cut deeper and get to the bone of what really matters. To the Bone podcast is a product of Daily LLC. It's hosted and produced by Shelby Daly, ATC, and Randy Daly. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. For more on the show, visit www.tothebonepodcast.com. If you enjoyed this episode, be sure to subscribe, rate, and leave a review. Get involved in the conversation. You can find us at www.tothebonepodcast.com. Drop us topic suggestions or be a potential guest. We're all about connecting with you, our listeners. Until next time, stay curious, stay grounded, and keep cutting deep.